Happy Friday, everyone. Going to be talking to the man, the myth, the legend today, Dr. Spetzler. Hey, how are you, Dr. Spetzler? How's it going?
Hey, how are you?
I'm good. How you doing?
Lunchtime for you, still morning for me.
I
I
hear you.
look
How's
forward to the interview.
how is Jackson Hole?
Do you really have to ask? It is
No, I
absolutely
don't.
spectacular.
I'm sure. I'm sure. I'm jealous, and obviously you deserve all that time off. But listen, thanks for joining us. I'm going to do a brief introduction just while everyone's logging on here. We have a real pleasure today to talk with Dr. Robert Spetzler, world-renowned neurosurgeon, pioneer, legend in the field, someone who really changed the game, so to speak. I can personally say he's someone who I've admired all my career. I remember meeting you for the first time back when I was interviewing in 2004 back at the Barrow. Seeing what you've accomplished, what you've built, really kind of drove me to also work hard and also hopefully achieve even half of what you've done. So going back, Dr. Spetzler was born back in Germany, moved to the U.S. at the age of 11. He received his undergraduate degree from Knox College in Illinois, his medical degree from Northwestern, and then residency at UCSF. He joined the faculty at Case Western, where he was rapidly promoted to associate professor. The big move, what we're going to be talking about today, was in 1983 when Dr. Spetzler left his established academic position at Case Western to become chair of neurosurgery, which at the time in a much smaller, little known private hospital called the Barrow Neurological Institute, part of the Dignity Health St. Joseph's Medical Center in Phoenix. The rest is really history. When the BNI was first opened its doors, they only had one operating room and 52 beds. By the time Dr. Spetzler retired as president and CEO of the Barrow 4 years ago, the BNI had become the largest neuroscience institute in the U.S., I would suspect also in the world, with 430,000 square foot neuroscience tower, 64 intensive beds, 80 acute care beds, 11 dedicated neurosurgery ORs, the first three Tesla intraoperative MRI scanner, two endovascular suites, 48 emergency bays, six trauma bays, and three MRI suites. Truly mind-boggling. I remember back when I was looking at the Barrow, people would call it was the Disney World of neurosurgery because of all that Dr. Spetzler had done there. So clearly one of the most influential neurosurgeons ever, and he's here to talk about his career, which has been absolutely spectacular, his techniques for building such a prolific program. And then we're going to discuss a little bit about our book, which is The Business of Brain Tumors, which we were fortunate to have Dr. Spetzler involved in. It was a handbook which we just finished writing. It just got published about 2 weeks ago, and it talks about building a patient-centric practice with optimal outcomes. So again, thank you so much, Dr. Spetzler, for joining us. It's a real pleasure to talk to you.
Thanks, Ricardo. Now I realize, after what you have said and all the accomplishments that you attribute to us, why I'm so damn tired.
Well, yeah, it makes sense. It makes sense. Honestly, seeing what you've done is truly mind-boggling. And today I just want to pick your brain a little bit to see kind of when you first made that move, and we'll just start out with that. Let's go back to 1983. You're sitting pretty. You have a great academic job at a very well-established program. You're doing great. Tell us a little bit about how the opportunity at the Barrow came up and your thought process on taking that at the time, what seemed like a risk to go to a smaller program, but with tremendous upside.
Yeah, it was a fascinating time. I was very young. I was, I think, 36 when a search was instituted at Case Western for a new chairman, and I was delighted to be included, but I also had enough of an ego that I thought I should have gotten the job. But when somebody else got the job, um, his and my philosophy of teaching were not particularly aligned. It was still a good time. I enjoyed it. But at that point in time, I looked at other offers. I was actually negotiating with the dean in New York at Einstein to take over the chairmanship there when this opportunity with the Barrow came up. I really didn't fit into the New York mold. I felt sort of that there wasn't enough light coming down through those tall buildings. So when I went to Barrow, I went with the admonishment from my wife that if I looked at Phoenix, I'd be going by myself, because she remembered going through Phoenix at the age of 10 in an unair conditioned car in the middle of July, said I'd never go there. But John Green, much to his credit, invited me and my wife, Nancy. We went, we loved the place, and fell in love with the people that we met there. The reason I really wanted to leave Case Western was I had an overbiding interest in establishing my own residency training program. And that was really my goal.
Interesting. So that's what drew you to the Barrow. But at the time, was anyone second guessing your decision to leave such a major program and go to something that at the time was kind of relatively unknown?
Yeah, pretty much everybody. In fact, is when my chairman, Charlie Wilson, who I was quite close to, when I told him about not taking New York, but wanting to consider going to Phoenix, he said, "You will wither in the desert." That means I'll disappear. We'll never hear from me again. But Ben Stein, who was a great skiing buddy and somebody I admired and really respected his opinions, he said, "Looks like a great challenge. Go for it." So I went, obviously, with Ben's blessing. And I just want to point out that Charlie Wilson, when he ended up needing surgery, he came to the BNI. And he was our first visiting professor and wrote a lovely note.
Wow, that is karma right there. I mean, what exactly about the Barrow, you said that it was the residency program, but looking at that diamond in the rough, were there things that you saw that other people didn't see? Did you envision the unbelievable success you've had?
Ricardo, I appreciate the kind gifts that you give me of looking at things and really dissecting them and seeing the positives, but I was way too naive. What I saw was that they already had a residency program. It was a borderline residency program at the time, especially with the loss of the previous chairman. And that was key. But what drew me to it were the people I met. I met people that were supporting the institute who I liked. John Green, who was the brilliant originator of the BNI. And I met a number of attendings and residents that I really liked. So I knew what I wanted. I wanted to put all my energy into a residency program. To do that, to create a strong, really relevant residency program, you undoubtedly needed subspecialization. So my first hurdle to get this accomplished before I committed to going there was having long meetings with the attendings, who were all in individual little private practice settings, and basically saying, you got to buy into the vision. And that means you have to give up this kind of a patient, but you can subspecialize in this area. And in the end, this is how, for example, Dr. Sontag, world-renowned spine surgeon, came into the fold. He was a private practice physician and solo practice. And I got his name from Ben Stein because Ben Stein was his chairman when he was a resident. And naturally, when you look at all at Volker Sontag's success, you can see how it all depends on picking the right people. Mm-hmm. So everybody ended up buying into the subspecialty program. And that's, I think, was the secret underlying hurdle that we had to overcome, and did.
So you talk about the residency, you talk about subspecialization. Were there any other priorities when you got to the Barrow? I mean, those seem like two pretty big challenges.
Yeah. I'm a very, very big believer in treating people with dignity and respect. And so I've always said that if I deserved one other degree than the ones I've had, it's a psychiatric degree, because I would have these people coming into my office, whether it was a neurologist or a psychologist complaining about this or that. You had to get people to line up. They had to sort of give up some of their own personal needs and ambitions in order to let the whole dream come forward. And I was incredibly fortunate in getting individuals that bought into the vision, and that required that people did not yell or scream, that there was no throwing of instruments, no raised voices. It was a matter, we need to be professional. And with some bumps along the way, people really bought into that, and I think that had a great deal to do with the success we had.
I mean, if you look at the growth of the Barrow over 3 decades, I mean, it went, like you said, from a very small, relatively unknown program to arguably the most dominant program in the world. You talk about that culture that you created, which is amazing. What else do you attribute that explosive growth to, going from literally nothing to something spectacular?
Yeah, Ricardo, I think again, it goes really back to subspecialization. If you do the whole gamut of neurosurgery, it's a terrific template of what is possible, whether you put in a brainstem stimulator or you correct scoliosis. But in order to make a difference, you have to focus on one specific area. Then you get competent in that, and then from there you can really push the envelope. You can initiate improved treatments. You maybe can come up with a totally different treatment. So with vascular neurosurgery, which was my own field, there is absolutely no difference that even with the last aneurysm I clipped, there were well over 6,000 aneurysms, I was still learning. And so just like an athlete, practice, practice, practice. Well, if you practice in one little area, you are going to be much better than whoever doesn't do that. And I think that is really the success of subspecialization.
Now you've called that the snowball effect, where people just like you do thousands and thousands of operations, and through that you become a true expert in that particular field. Did you get a lot of pushback from your faculty? Were there people who said, "No, look, I want to do general. I don't want to specialize"?
Yeah, there were some holdovers that general. This was not a sudden 180-degree change of the way things were done. But I think it became so obvious that when a non-vascular specialized neurosurgeon was doing an aneurysm or an AVM, that they would get into trouble, that I would be called or my colleague would be called. And so it evolved into this subspecialization that really did not leave a lot of unhappy people in its wake. And I think that's very important.
Yeah. You know, moving on to the book, which we were fortunate to have you involved in, talking about practice building and kind of how to build a program, what those techniques are. You know, having obviously read the book and you wrote the foreword, did you feel like you instituted a lot of those techniques when you were building your own name and your own practice?
Yeah. You know what, as I was reading, I said, you know, I should have written that book instead of just the foreword. Yeah, it's just common sense. I can tell you that I think to be successful, everyone that is successful borrows and steals from teachers, from their friends, from their colleagues. We take what we think is good, we recognize what isn't and reject it, and thus build our own way of doing things. And one of the biggest lessons I learned was really from Charlie Wilson, my mentor, who, when he came to San Francisco, I think he had 3 private patients his first year, 3 private patients. He ended up with one of the largest specialized practices in the United States. And how did he do it? He never rejected a referral, no matter what. as a resident, we would get patients that were bleeding out of their back because they were on Coumadin and somebody had attempted to do a spinal tap. And when we asked them why this patient, who was really not an appropriate neurosurgical patient, was admitted, he said, because that referring physician is going to get other patients who are more appropriate. And by taking care of their problem, if they call you and have a problem, you're the specialist. If you can help with that problem, you will have made a friend and a reliable referral physician. So I incorporated that. So how did he do it? He called back the referring physician after every operation. Our admitting summaries, we sent as a letter to the referring physician. The same thing with the discharge, when there's a letter to the referring physician. So the referring physician was really receiving all the information that happened to his or her patient. And most referring physicians, when asked, their complaint when they send somebody to a specialist is that they never see or hear about their patient again. So that is something I incorporated. I would dictate all these letters on my way to work or from work. So I think that is one of the lessons that is really key in building and maintaining a practice.
Now, how do you get the rest of the faculty to buy in? Because, I mean, I'm sure, as you know, right, I think a lot of physicians go through medical school, residency, fellowship, and they feel like they should just hang up their shingle and patients should be showing up. You know, the world does not work that way, and you have to work for these referrals. How did you?
Yeah, you know, it is so much the person. When I think of somebody like Charlie Drake in London, Ontario, who built this huge aneurysm practice in past decades, Al Rotan, and these are towns that are not known as medical centers. It comes down to the individual. And the ivory tower concept, which was much more prominent when I entered our profession in the 70s than it is now, still was very, very prominent and very, very, very wrong. I couldn't agree with you more. The ivory tower concept has no place. It has no relevancy. It's like royalty. It's like royalty. You're not imbued with powers that you don't deserve.
And so when you were hiring faculty, right, people wanted to work at the Barrow. You saw people that came out incredibly well trained, technically great. How do you spot the intangibles of people that are gonna get after it, grind, put in the work outside of the operating room, which you and I both know is just as important as the work in the operating room?
Yeah. You know, I looked for two things in the people that I wanted to associate with. One was they had to have an incredible passion for a specialty. This is not a specialty that goes from 8 to 5. It is one that really requires your complete dedication. And so not only do you have to have that passion, but you have to have family that supports that passion. And then naturally comes ability. You've got to have that ability to be an expert neurosurgeon, but also to have the qualities that go along well with it, that you can work with others, that you will not abuse the nurses or the staff or the residents, etc. I remember one attending that we had who, when we had the blind reviews after, that go along with the residency program, he came into my office, he said, "We've got to fire these residents." They gave him absolutely terrible marks. And I turned to him and I smiled. I said, "You got it all wrong. This is how they reviewed you. You should look in the mirror." Well, this attending, who's really brilliant, very talented, got the best review the next 6 months rotation. So people can change, but they have to recognize that if they came from an abusive program, they're likely to accept abuse as they go forward, just like with families with abusive individuals. And that just is not acceptable in my shop.
Yeah, I mean, I think again, I think you created such a wonderful culture there where everyone is striving for greatness, working together, understands the business aspect of medicine, which is what we're going to talk about now. I mean, just like we mentioned in the book, people spend 7, 8, 9, even 10 years learning how to do neurosurgery, but at no point in time is there formal education on how to build a practice, how to get the patients, how to build a program, and kind of, everything you've done. Why is that? Do you think that there should be formalized training in terms of the business aspect of medicine?
Yeah, I've thought about that some, and I don't think it should be a portion of the residence curriculum per se, not because it's not very important, but because residency programs are so incredibly varied. Some are strong in this, some are strong in the other. I think a better strategy for that is actually for you to put together programs at our national meetings specifically designed for the resident or fellow or young neurosurgeon that's about to go into practice, because the practices are so different. You have the academic model where they really don't need to know much about the business portion of the practice, but need to know the fundamentals that you've already addressed with the 3 A's. And so the book is good for them, but it's a totally different need for the resident that wants to go out into solo practice or the resident that wants to go into a group practice. So I think you have taken on this mantle. I think it's a very, very important mantle. And you should be initiating courses that address these points in a manner that is accessible to all the residents.
That's an amazing idea. I hadn't really thought about that, but it certainly makes sense. And I see your point in the sense that the residencies are so varied. Some residencies may have people that have surgeons that are very busy, very business savvy. Other ones may not. So it is hard to kind of make it uniform. But I love the idea of speaking at the national meetings for the chief residents, for the fellows who are going to be finishing. Do you guys have anything at the Barrow? Do you encourage residents to be in clinic to see how high volume surgeons run their clinic? Is that at all part of your curriculum?
Yeah, patients, I couldn't agree more. I mean, a resident who does not see the patient right up front and in follow-up is missing the continuum of what patient care is all about. Not only that, is that when a patient is discharged from the hospital, they may appear to be barely functional. And when you see them 6 weeks later, you can see that they have returned basically to normal life. So that sort of continuum of seeing the problem, taking care of the problem, and following the patient up, I think is a critical portion of the teaching process. And our residents are in the clinic. They have specific rotations, whether it's vascular or whether it's functional or whether it's spine, so that there's really a continuum of learning from A to Z.
Yeah, and I also think that being in clinic is important because even though someone may need surgery, it's a whole nother skill set to convince someone that you're the person to do that surgery, to kind of instill that confidence, make them feel comfortable with you going ahead. That's a whole nother skill set other than just the technical aspect.
Yeah, it's a good point, Ricardo. Additionally, it's equally important to see how many patients you see and then you recommend no surgery. In fact, it's one of my favorite papers I wrote with the chief resident then, Patrick Hahn, was we looked at patients that were sent to us for AVM surgery. These were grade 4 or 5 AVMs that were sent to us for surgery. We reviewed them all in conference. Out of those, and the reason we did that is because we were accused of or criticized for having such good outcomes in our grade 4 and 5 patients, which really had a 20% morbidity and mortality, but for that kind of AVM, considered to be relatively good. But out of those patients over a 2-year period that were sent to us with these terrible grade 4 and 5 AVMs, in only 5%, 1 out of 20, did we recommend resection. In some of them, we recommended partial treatment because they were having flow reduction neurological symptoms. In others, we might have recommended an aneurysm clipping that looked very dangerous. But in 95% of those grade 4 and 5 patients, we did not recommend surgery. So clearly, when you take the other 5%, for them to do better than if you operate on all of them is very obvious. So it's really a matter of selection that is key to patient success.
Yeah, I mean, I always tell our residents that patient selection is pretty much 95% of your outcomes. If you pick your patients well, you're going to have good outcomes, few complications. If you operate on everyone, it's going to be a disaster, and you're going to have a lot of complications. I just want to wrap up in the last 4 minutes. I want to talk about the 3 things that you talk about in the book that were critical for the Barrow kind of exploding with patients and overall success. Accepting challenges, rejecting norms, and pushing boundaries. I think this is an absolutely critical message to send to everyone. What did you mean by accepting challenges? You mentioned it earlier, but I wanted you to get into it a little bit more.
Yeah, it's we're going back again to subspecialization, because only when you do a case more than once can you learn from the previous case. And challenging cases teach a great deal to you, and you make mistakes and you learn. It is absolutely critical that when you make a mistake, it's dissected, it's got to hurt, and you got to learn from it so that you can benefit the next patient around. That was my grandson.
Adorable.
Okay.
I just want to give you a hug.
Okay, buddy.
Adorable. Absolutely adorable.
Okay. Yeah. So I'm always very, very unhappy when I see a resident or attending not taking a complication to heart, because that we have to learn from. So by accepting challenges, that experience allows us to take on the more difficult case, maybe the one we thought wouldn't be appropriate for surgery previously. And that is really accepting challenges. And the same thing with the next one I know you're going to ask is rejecting norms. Well, we are befuddled by past ways of doing things. For example, virtually every residency program taught opening the head, opening the dura, placing a retractor, rigid retractor, and creating space. Over the last 15, 20 years, I have moved away from rigid retraction altogether, so that when Sanai and I wrote the paper, I think it was 96% of cranial cases, we never used a rigid retractor. That is rejecting a norm. And that
takes a lot of confidence, though. But that takes a lot of confidence, and it takes yeah.
Well, no, Ricardo, it takes confidence. It takes evolution. We've got to stop. Every case, at the end of the case, I ask the resident, review what you did, see where you could have done better. Do you need that whole exposure? What can you do to make it faster but safer? And utilize that for the next case.
Yeah, I mean, it's that perspective of it's never good enough, and the moment you become complacent, you're falling behind. Would you agree with that?
Yes, I agree completely.
Well, listen, thank you for your time, Dr. Spetzler. It looks like you got family time.
Yeah.
Grandson was totally adorable.
Yeah,
I've got to
go now. I've got to go out there and hug him now.
Yeah, it seems like you have more important things to do. But I wanted to say thank you so much. Again, you have been a role model for me my entire career. What you've accomplished, very inspirational, really motivates me to always improve every day. This has been a true pleasure, and I want to say thank you for taking the time.
Yeah, thanks, Ricardo, and great book, and good luck with it.
Take care again. Okay, take care.